Here's just, I showed you a few models that have been shown to improve quality and reduce cost, and here's a whole bunch of others that have randomized controlled trial level data about them. We do not need to find out whether these models work. We know they work. We're just not implementing them. Why aren't we? I think nobody knows what to do. Part of it is there's so many of them. Nobody knows even where to start, which one to use for which patient population and what setting, and we as a field are not helping. We in palliative care and geriatrics are not doing the work of helping health systems understand which models they should employ and how to target the population that will benefit from it, and which models might not be such a good fit for their system. And I think that's the big task ahead of us. Which models are linked to quality? What are the outcomes to measure to prove that quality and costs are improving? So what we need to do is take kind of a leadership role to advise our healthcare system. And these are the 5 factors listed here that have been shown to be associated reliably with models that improve quality of care and reduce cost. So no matter what model you are applying, your checklist should include these 5 factors. Okay? Does your model target the population likely to benefit? Does it involve goal setting, advanced care planning, and discussions about what matters most with patients and with families? Does it involve explicit evaluation of family needs, family vulnerabilities, and provision of support for family caregivers? Does the team have expertise in pain and symptom management? Because if they don't, where is the patient going to end up? In the ED. And can this model be flexibly dosed? So for example, hospice, it's $160 per day, whether you have no needs or whether you have intense needs. Same cost, same intensity of the model, regardless. So it doesn't adjust in terms of the reimbursement according to the intensity of services need. We need models that understand that most of the time people are stable and don't need much. They need a 24/7 phone number for when somebody falls getting off the toilet. But some of the time they have very intensive needs and need a nurse practitioner to go to the house and start an IV. And that costs a lot. So we need models that can adjust and be flexible in their dosing. And this is the way insurers think about this targeting issue. This is a slide from South Carolina Blue Cross Blue Shield. In the x-axis, we have patient need. In the y-axis, we have cost of intervention to manage the care. So you're an insurer, right? Think for a moment you're an insurer. Your job is to reduce the money going out the door. So I have United Healthcare. I'm pretty healthy. I never go to the doctor. I'm in the demand management category. What does United Healthcare do to manage my demand? They send me emails about yoga and fruits and vegetables and exercise, trying to remind me, encourage me to have a healthy lifestyle. I wish I could say it's because they love and care about me, but they're actually trying to reduce my utilization. Good. I want to reduce my utilization too. Say I go on and I develop hypertension because I don't do yoga, I don't eat fruits and vegetables, and I don't exercise. They'll see a claim for hypertension and a claim for hydrochlorothiazide prescription. All of a sudden, I'm going to get an email a month on hypertension and stress reduction and salt and diet and exercise and medication adherence. They're going to ratchet it up. It's still cheap, but it's more customized to what my needs are. Say I completely ignore those emails too and end up having an MI and ending up in the ED and the CCU and the hospital, and they see a very large claim, and they see now a diagnosis of hyperlipidemia and diabetes in addition to hypertension. Now they're going to assign me a human being because the email is clearly not working. Unfortunately, they're going to assign me a human being who lives in India, and the person who calls me is different every time. So I don't establish any relationship with that person. In fact, when I see that on my dial, I don't answer the phone. because I just feel harassed. So what happens? I have another MI. And now I'm in heart failure, and I've had a very costly hospitalization and a very costly rehab visit. So now they realize that none of these cheaper methods work, and that the only way to keep me out of the ED, the hospital, the CCU, the rehab center, is to actually send somebody to my house and take care of me and understand what the social determinants are. Why am I so depressed that I'm not taking my meds? What's going on with my family? Do I have transportation to get to the doctor? Am I eating? So they're going to send a team to my house. Very expensive, but much cheaper than usual care. So this is how insurers think about it. This is not how Medicare fee-for-service thinks about it, unfortunately. But this is how Medicare Advantage thinks about it, and increasingly how ACOs think about it. Because if they don't manage the costs of the sickest, costliest 5%, they will go under. So get this framework into our heads.